me begin by saying something from really an observer's perspective. If there's any area in nursing that is young, it is neuroscience nursing. Prior to the MRI and the CT scan, I guess, both in the 60s and 70s, if I remember correctly. Understanding what was going on in a person's brain was quite difficult, and so diagnosis was difficult, treatment was difficult. And there were several other problems that attend to neuro injury, including the inability of the patient to express himself or herself, and the suddenness with which it frequently occurs, and so on and so forth. So it's quite a traumatic thing. What brought you to neuronursing as opposed to another specialty that could have been just as challenging medically? I imagine oncology is pretty challenging, and pediatrics, and all kinds of things. We're going to give Ann a rest for a moment. And why don't we start with you, Dan, and start at that end of the table. What brought you, why did you choose this specialty?
Well, I chose nursing, almost 21 years ago, with a lot of help from familiar people. My mom sort of directed me in the right direction. And the reason I chose neuro at the time was it was very challenging. I felt it was bad things happening to usually good people unexpectedly. So no one ever really knew what was going to happen, and it was a time that I felt I could really help them in a very tough choke point of their life, and to sort of get them through usually a bad situation and provide the care and the ability to help them get better over up to a month or longer through the acute care.
And Cathy, how about you? What brought you to turn?
Well, I've kind of had a varied career in a lot of different areas, and I end up going into the back door on a lot of things. And do you need? Is the mic on?
Yeah, if you could bring your mics closer to you, that would be helpful.
I just said that I've had a varied career, and I've kind of come through the back door of many things. But about almost 4 years ago, I came to work at the VA in Bedford, Mass, and was really astounded at the number of traumatic brain injury patients and some of the issues that were going on.
These are veterans from
Iraq. Yes.
From Iraq.
Traumatic brain injury has become known as a signature injury of the Iraq and Afghanistan wars, unfortunately. And the thing that really worried me a lot was the fact that a lot of them show no physical outward signs. So unlike people who have been through trauma, and you can see by their limping or their assistive devices, most of our traumatically brain injured patients have no outward signs and symptoms unless you know them well. And that really compelled me to look at that a little bit further, and ended up becoming part of the traumatic brain injury secondary level screening team at the Bedford VA. And I'm where I should be. That's all I can tell you.
That's a good thing to be able to say. Shaun, how about you?
Other than it was the only job available out of school.
It's not the answer we're looking for, Shaun. Try again.
No, I had before I had gotten into nursing, I had done some time on an ambulance, and we had some of those calls were when people could not speak for themselves, whether it be a stroke or some kind of traumatic injury, and it always fascinated me around how I'm just dumping them in the emergency room and my job is done, but how do they communicate with those people? How do they tell you what's wrong? And it kind of got me into in kind of exploring a little bit more. And I had a friend of mine that was at Simmons in their nursing school, and she said, "Well, why don't you go into nursing and find out?" And so, and that's how I ended up there.
All right, we're back to Ann. You ready?
Yeah, I think, as I said, or as was said in the video, I got involved in neuro, here at BC. And I actually, when I came back from Jamaica, I figured I'd spend a year or so in neuro, and that was 43 and a half years ago. So, but actually when I think back over the 4 decades, the amount that neuro changed, it was always so exciting. I mean, I was there CT scan, pre-MRI, and how it's evolved in 4 decades is just constantly exciting to me.
I want you to talk about that, because I think you know, it is almost as though the ability to do neuronursing, or it's just I don't know how you did it before, how anyone did it before CT scan and MRI, when you could actually view the trauma, and perhaps you could talk about the trajectory of what we do now, what we know now, as opposed to when you began in the late 60s.
Well, for myself, I think we relied, which we still do, very heavily on the patient's clinical assessment, their level of consciousness and what they were portraying in terms of their neurological condition. But as we became more sophisticated, we were able to delve into, literally and figuratively, their brain and find out things first on underneath the bone, then on the cellular level, and so on and so forth, which is now what we're able to do. But it changed so much that it was almost, I think, people that are surviving now would never, ever have survived 40 years ago. So it's just added a whole new area of specialization.
Have the three of you also seen a tremendous difference in the way you're able to analyze, treat, understand what's going on in your patients, as that Ann was just talking about? Have you seen a similar thing during your careers?
Yeah. Well, I think that, so we're in the realm of critical care, the sickest of the patients that are in the hospital. And I think that even though the technology that's out there is, just amazing, the ability to measure pressure and oxygen and everything actually inside the brain, it still is back to your basics, before CT, before MRI, is that the nurse puts their hands on the body of the patient and minute to minute can assess what's going on, minus the monitors. It's your ability to do a actual exam and kind of watch them get better, get worse, and then that's going to be able to dictate, kind of some of the things you're doing. So it goes back to, we have all this technology that's fabulous, and as a director of a unit, I've got to then orient people to this new technology, but it goes back to the bedside exam and really mastering that.
It strikes me, the new technology, I'm my office Luddite, by the way, this is, but it strikes me the new technology must be difficult, a lot of training, a lot of re-education. Has that become a problem for keeping people in the field? That is to say that they have to know and be able to do and train so much more than they used to. Is that an issue in neuronursing? Anybody?
Yes.
Okay.
In a word. It's a joke in our unit that if you go on a 2-week vacation, you have to get a retraining course, before you can start back to work.
Sure.
But it's constant. The new equipment, the new technology, the way to monitor patients is changing almost monthly. I'm sure you'll agree. So it's a lot to catch up on constantly.
I want to ask Dan Triggs a question. I mean, we have heard an awful lot and read an awful lot about the, brain trauma or head trauma being one of the signature injuries coming out of the various wars of the last decade. Can you describe what you have seen and something of how this has evolved over the years? I mean, someone who suffered the kind of brain trauma, say in World War II or Vietnam, that you saw in Germany would not have survived a trip to the nearest medical center, much less
Right.
a trip to
The TBI is something that has come to the forefront of nursing and in the medical field. As Cathy was saying before, people who are traumatized by TBI, they don't usually have a bodily injury. It's when the brain receives a force, a contra coup force, and it affects them for a very long time. A lot of the patients that we saw in Germany were blast patients, patients who were caught in a Humvee, patients who were shot, patients who were just receiving traumatic injuries. And when they wake up, they don't remember the incident, they don't know how they got there, they don't know where they were. And what we ended up doing was we would try to perform a very simple baseline TBI screen, and we made sure that every one of the sailors or Marines or anybody who was having to deal with the service ended up getting their baseline screening before we sent them back overseas to either Bethesda or to Walter Reed. And Walter Reed was the big receiving facility east side of the Mississippi, or they'd go back to San Diego out there. And so depending on what service and what branch they were, that's where the service member went to. So the Navy personnel went to Bethesda.
Sure.
The Army went to Walter Reed. And then, like I said, anybody would go on, would go beyond. But the hard part was trying to transition these patients who were, most of the time they were intubated, sedated, and you didn't get a baseline for those patients. But all of the ones that were able to ambulate or carry on a conversation, we ended up trying to do a simple baseline cognitive screen that went with them from downrange, as they would say, from the time of injury, coming to Germany, and then from Germany, when they were transitioning back to the States and to eventually to wherever they ended up.
But the notion I have just from reading the paper, and in fact there's a brief profile in the current Boston College magazine of a neurosurgeon at Walter Reed. It's on the inside back cover. It's called Works and Days, and who's been doing traumatic brain injury kinds of things. And what one reads is that we have learned an awful lot, albeit in an awful way, about how to deal with this kind of trauma just because of the enormous numbers and the problems that the medical personnel face. So someone who might have seen a kind of injury 10 times in a year is now seeing it 10 times in a week and so on. Can you say something about that, or you, Cathy, on the basis of your VA work?
Well, I can take it from a different perspective.
Please.
In that they're all, the patients that my colleagues are all seeing, obviously near death's door, are very traumatically injured, and usually a polytrauma in addition to the brain injury. The concern more for me, and not that I'm not concerned about them, but they're going to get good care, is the patients who are experiencing traumatic brain injury at the front lines but don't get the care. Why don't they get the care? Well, they've told me. They'll say, you know what, when I see my colleagues being shot and killed and or losing a limb right there in the front lines, my little problem seems insignificant. And so therefore they don't get assessed or treated. And then when they come back, if they're being seen at a veterans care facility, they do get screened. As Dan was mentioning about the screening, it's becoming more and more universal, but it is not everywhere. And with such a small percentage of veterans who are going to VA care, I worry about those who are out in the community, have experienced personality changes, have experienced trauma from this TBI, but nobody knows it, nor do they. For some, it's even enlightening to hear when they learn that this is not just all in their head. It is in some ways, but it's not. And that they're being screened and realize that there's actually a reason why they are feeling or doing or not being able to do what they could do before.
So this is concussive injury, if
The
I can call it that.
concussion, yep.
We don't see trauma of the
Exactly.
head, no bleeding, no nothing, but
Right.
you're in the Humvee, it explodes underneath, and the pressure concusses you. You don't even know it.
Right, and they hit the side of the wall of
Hit
the
the-
Humvee, or they fall off and hit their head.
Right.
It's interesting because when I have done a talk on this called hiding in plain sight, because they are hiding in plain sight, nobody can see that, to look at them. The big thing is that the advances in military equipment has really brought this to the forefront. In that, what you mentioned before, is those soldiers from the past would not have survived this. Now they are surviving because of better equipment, because of better vehicles, as well as their own personal equipment that they wear as soldiers. They are surviving, but not without some consequence. And so our knowledge and expertise in this area needs to catapult forward. We're making progress, but it's slow. We're really behind the curve as far as taking care of and helping these men and women who are coming back.
I've had in my lifetime, two encounters with two loved ones who had neurological diseases. My beloved stepfather had Guillain-Barré disease, and I know you're all familiar with it, and I'm sure many in the room are familiar with it. If not, it's a progressive paralysis of the nerves. And my mom, who's had several strokes. And to me, the worst thing about both those occasions was my inability, and everybody's inability, frankly, to communicate with them, to know what they wanted, to know what hurt, to know what was going on inside their heads, no pun intended. I wonder how you, and I'll start with you, Ann, how you deal with that problem of reaching, trying to understand someone who really can't communicate. We were holding up letter boards. I'm sure you've seen this, and point to a letter, and a brief nod tells it. How do you work on that? How do you get good at that? And how do you communicate with someone who simply would seem to your average human being, even a beloved son, to be unable to communicate? What is it?
Well, I think you have to use certain commonalities, but also individualize it. And I had a lot of personal experience with it because my brother passed away with a brain tumor, and so for many, many years he was aphasic, unable to speak or to completely understand. So we worked at a lot of things on the home front besides in the hospital. But I think you do use things like you do what you think might fit the situation. A letter board, trying to help people point things out, trying to anticipate, trying to show them pictures, also always involving the family. Always, because, they oftentimes, can understand better than you can, and then in a number of instances, the patient will revert back to their original language if they had something other than English as their original language. And so getting somebody to help in that vein too. So I think there's a common thread of never believe that the patient can't understand or can't hear you, always presume that they can, and then sort of trying to individualize it to their particular needs.
That would be true even for patients who are said to be, I don't even know if this is the right word, in a vegetative state or in a coma or something, always assuming that they can hear everything and understand.
I would say yes. And just to touch on, we talked about technology, and one of the physicians at at the hospital is working on just this thing where they connect these probes, little electrode connections to the head, and they're screening for this thing called a P300 wave. And what they'll do is they'll flash letters in front of a patient that is not able to communicate. And they'll flash letters and kind of home in on what the letter the patient sees. They see spikes in these P300 waves, and then they'll move to the next letter. So that they're using these brainwave spikes actually to help them spell out how they're trying to communicate. And there's locked in and a couple other syndromes that we see frequently in the ICU. That this is kind of really cutting edge research that he's doing. We don't see a lot of the patients, but it's an interesting kind of that technology approach where we've relied on talking to the patient and assuming that they know what we're saying and believing that they hear us. But this is kind of the next level. It's pretty amazing.
I'm wondering if the rest of you, Cathy and Ann, could comment on the communications aspect and how. What part of it is intuition? What part of it is training? What part of it is experience? How does it work?
Well, I feel the training comes from the concept of getting to know your patient, and you have to get to know your patient very quickly because you are their voice. You're the one who's talking for them and doing everything for the patient. So getting to know them on a quick basis is what helps to move along the process. I always try to get the family involved. They're asking me if the patient's unresponsive. They're saying, do you think they can hear me? I'm always encouraging them for them to talk to them. One thing I tell them that if they're going to respond, they're going to respond to you because it's a voice that they're familiar with. It's certainly not my voice or anybody else's in the room. So if they're going to recognize a voice, it's going to be the patient's family and certainly not mine. And then I try to incorporate the family. I sometimes say it's like playing charades almost sometimes,
Of course.
And I take the situation if it's around a mealtime. I know, we'll start talking about likes or dislikes with the food. I've always encouraged the families to tell me what they want if we're trying to pick out a menu or something. But for me, it's always trying to incorporate the totality of taking care of the patient and the family.
Cathy, do you want to?
Well, again, on a different perspective,
Please.
but one of the things is that most of the patients I see are able to communicate. Are they able to communicate clearly and easily? Not always. But one of the things we're looking at doing is helping them to find new and creative ways to make sure that they're being able to communicate. For example, I was mentioning before, a lot of patients, because they're veterans, they have the GI Bill and they can go back to school and earn degrees or major in whatever area they're interested in. However, a lot of them with TBI are not able to do that as easily as one would think. Partly because perhaps before the injury they did really well and things came easily to them, and it does not come easily anymore. So the VA and other places are working with these patients and helping them learn things like there's a program called the Brain Train, helps them sort of reorganize how they think and how to measure and move forward. There's a lot of assistive devices, so I have to say I'm sure my colleagues would agree that the computer generation has certainly revolutionized some of this, helping patients with PDAs and or iPods. All these things have been other tools that they can now use to help them to learn, and it gives them a lot of hope. And I think that's the biggest thing that hopefully we all can do, is give the patient some hope and their family, no matter what the situation is.
Yeah. I want to stay on the topic of patients for a moment. Ann talked very movingly about her colleague's husband and what she was able to do, she and the staff were able to do, and how it was perceived by your friend and her daughters and so on. And remarkable story. I wonder if the other three of you have a story about a patient that would illustrate for everybody the challenges and rewards of the particular kind of work you've chosen to do. Is there someone, a person who comes to mind? It could be, someone you studied with. Ann also mentioned the nurse she was with on the ward, I guess, right after you graduated from BC, or who was very excited about neuronursing, and it gave you a sense of possibilities. Does anything come to mind in terms of something that would illustrate in your own lives how this particular kind of care works?
I was working one day and ended up receiving a patient who had he underwent a subarachnoid hemorrhage while at the gym, and turned out he was a pretty high-profile sports commentator. And to see him come through the ICU, I was his primary nurse for 3 weeks, taking care of him, and all the things that he went through, which our normal patients go through, getting a drain put in their head, having mental status changes, really not making much sense when they're talking, trying to re-educate them on just basic habits of ADLs and feeding themselves and getting to the bathroom. And to see him back on TV nowadays, where you would never know that he suffered such a traumatic event. And he was one of the lucky ones. Not everybody who ends up with a subarachnoid hemorrhage can say that they've actually made it back to their baseline. So for me, it was a great experience to see that we were able to get him from point A through a very traumatic period of his life, and actually get him back on TV, where you wouldn't know, unless you were a sort of trained person or knew his story, that he suffered a grade 3 subarachnoid hemorrhage, and had done, it took him almost a year to get back, but he's back on TV, and he looks great.
Shaun, do you have, is there something?
Yeah. So I had an interesting one when it was a few years ago, when we had just opened the unit a few years prior, and I was actually the nurse in charge of the ICU, and we received a ruptured aneurysm. He was, the physicians batted back whether it was a grade 4 or grade 5 subarachnoid hemorrhage. Either is very, very bad, and he was with us for a good part of 3 weeks, and did not look like he was going to recover to any functional status whatsoever. They went through some of the procedures where they trached him and gave him a feeding tube, and nursing was kind of getting frustrated, that he wasn't waking up, he wasn't getting better, and they would go to the physician and would say, what, are we gonna make a difference here, and because we want to make a difference, and we're giving them this great care, we're just not seeing any fruits of our labor. And he said there's no radiographic evidence, no x-ray, no CT, that he's not going to get better. So we kept driving on and kept going, and he just wasn't waking up. But we're going to send him to rehab, and we're getting him all packaged up and ready to go to rehab. And I happened to be his nurse that day, and his eyes are opening a little bit, and So he has a trach, so they're breathing through the tracheostomy. So I just, on a whim, I said, let's just put the balloon down and plug the trach and see if he can talk. And I said to him, I go, you kind of looked at me when I did it, and I said, you've been asleep for about 3 weeks. And this is the God's honest truth. His first words were, why didn't anyone wake me up? So he went off to rehab, and we have a yearly conference, and we invited him back to our Neuroscience Nursing conference. He walked on a boat, and we told his story, and it was just amazing. It was by far the most amazing story I've had. So.
That's great. Kathy, is there something, your story?
I guess I'll speak more from a personal, more on there's 3 levels of health promotion, which is primary, secondary, and tertiary. My colleagues here are all dealing with tertiary, and I have a little more leeway because I get to deal with all levels for the most part and love to focus on primary and secondary. So I'll go with secondary, which is I have a niece who was 10 years old, and she was diagnosed with an AVM by incidental finding. She was having headaches, and they did a CAT scan, and they found
What is an AVM? I'm sorry.
An arteriovenous malformation in the brain, which a lot of times this isn't found until someone has a stroke, and sometimes at a very young age. So very frightening for her family and ourselves. This care that she got was space age. It was sort of like Star Trek. She actually went to Stanford University because she was in California, and they did a cyberknife procedure on her 3 different times. And can you imagine this fear for a 10-year-old girl to be going through this? She did awesome. And finally, at the age of 16, was told that they didn't need to see her anymore and that she was essentially cured. And so it's amazing. If you think about, I hadn't heard of cyberknife procedure, and I consider myself fairly in the know. But now I've recently heard that I think Boston Medical Center has a cyberknife procedure and stuff, and here it is. I'm happy to tell you my niece graduated 2 days ago from high school, and she'll be attending St. Anselm's College in the fall, so I'm very excited.
I have to ask, what is a cyber knife? I mean, I'm sorry, I just don't know.
I know, I'm not even sure I can tell you exactly. What's fascinating about it is it doesn't, it
It's
cuts.
not an incision?
It is not an incision, no. It is not an incision at all. Her head is placed in a certain type of helmet, and they pinpoint exactly where the AVM is, and they go in with the cyber knife. It's almost like a laser, and slowly but surely try to seal off the area of weakness. And she had to have it done 3 different times. And you have to be awake for this procedure, so you can imagine just the stress of that, because they will begin, if the symptoms begin to just show up that she might be having a stroke or end up having some neurological deficit, they can pick it up right away and they'll stop the procedure. So,
Please.
space age.
We're going to turn to the audience in a moment, but I'd like to ask one more question. As I look at the portfolio, if you will, of long-term neurological conditions that have to do with aging, and I'm a baby boomer, and there may be a few other baby boomers in this room, and I don't know. But the prevalence of Alzheimer's, of various forms of dementia, of Parkinson's, of stroke, is certainly going up. I mean, there's no doubt about it. People are living longer, and they're not dying of other things that, might have killed them at a younger age years ago, and so they're developing, particularly dementia, I guess. I don't know, I'm guessing. What does this mean for your profession? I mean, what are the important breakthroughs you would look toward that might be helpful in the resolution of what seems to be a kind of tidal wave of neurological disease that we'll be living with? I forget the estimates. The number of people in the year 2030 who will have dementia or Alzheimer's is a phenomenal figure when against the population. So what are you looking for? What do you see as what are we doing? What can be done? What are the signposts of progress in treating these diseases?
Well, I think that the stroke education is sort of the. Sorry if I stole you.
No, I was just what I was going to say.
Stroke education is really on the forefront. You can't do much about a stroke. There's not a lot of warning
Warning.
signs to them. It's not like having a heart attack where people will say, oh, they have chest pain and they either ignore it or they don't ignore it. Stroke usually comes on very quickly. So educating the patient, the population about the signs of stroke.
Right.
You'll see TV commercials, stroke time is brain is sort of a common term that you hear. And just getting the information out there on people on having to get to the hospital within 3 hours if
Right.
you're going to receive any type of thrombolytics or any type of treatment to help retrieve the clot that's causing the stroke. So the big thing in the forefront that I would think is education for the public.
And you agree with that?
I was just going to say the exact same thing. I think brain attack has become a more household word,
Right.
if you will, alongside of heart attack, and people know that they have to get to the hospital in a short window of time, and they are. And many, many, many people that we see in the unit their situation is being reversed, or at least partially reversed, because they're getting to the hospital so
Quickly.
quickly. That wouldn't have happened 10 years ago.
No, it's true. It's true. How about you, Shaun? Is there something?
Yeah, I mean, I think the stuff that's being done in the labs. Your next Nobel Prize winner will be someone that discovers some marker, some way to diagnose this. In particular, Alzheimer's, and because it's just, you're right. I mean, there's more coming, and also the ability to differentiate between all of these different things, because sometimes that you're labeled with something, and in fact you have something else. So being able to differentiate between the different disease processes early in the state.
And our ability to differentiate among different forms of Alzheimer's or dementia, how sophisticated is that?
I think that's an area that there's a lot of research being done, where they're looking for biological markers, where they're looking for familiar traits. There's a lot of things that they're looking for. A lot of the, talking about the concussion work, there's work being done over at BU by Robert Stern's lab around looking for markers. He's the gentleman that's getting all these athletes' brains.
Right, okay.
And he's looking for markers in there, and a lot of them are very similar to things that you would see in an aging brain. So,
Yeah. Cathy?
We actually have a brain bank at our facility, and they're working with Boston University. Dr. Ann McKee is the researcher who has done some fabulous research, and she actually does a histological evaluation, so takes slices of the brains and actually looks and shows without a shadow of a doubt the differences between patients with traumatic brain injury, patients with what they call traumatic encephalopathy, so they've had repeated injuries and insults to the brain. And they're also doing research. We have research on Alzheimer's disease, and they're looking at the different types of Alzheimer's as far as the tissue goes. I can't say, I can tell you they're honing in on some very interesting things. And I think it's important to say that's how we begin to look at what happens, and then how can we backtrack to sort of prevent it. And I guess from the primary care provider in me, I have to say that one of the ways that we've helped prevent strokes and stuff is great education with patients, talking about managing high blood pressure, talking about cholesterol issues, talking about using baby aspirins. Some basic things, talking about stress and its impact on the brain and blood pressure, et cetera. So I think there's a lot of education we can do on all three levels, and obviously if we can prevent something, that's the best level to look at.
Right.